Good morning, everybody. This morning we've got Dr. Hervin Heeroo, one of our registrars, presenting on Zenkers Diverticulum.
Thank you very much, Yaku. Can you hear?
Yes, we can hear.
Okay, thank you. So, good morning, everyone. My name is Hervin. I'll be presenting on Zenkers Diverticulum today. Consent was obtained from my patient, and all my content is referenced. So I'll start off with a case presentation of a 58 years old female presenting with a 2-year history of dysphagia to both liquids and solids, halitosis, noisy deglutition, and associated weight loss. She had a 30-pack year smoking history, but did not consume alcohol. On examination, she was well, with no associated neck masses or lymphadenopathy. Flexible nasal endoscopy showed mobile symmetric vocal cords bilaterally and no mass lesions. Contrast swallow was done, and it showed a diverticulum arising from the midline of the posterior wall of the distal pharynx at the level of C5 and C6, as you can appreciate in the videos. So the patient was taken to theater, and we did an endoscopic carbon dioxide laser diverticulotomy under general anesthesia with oral tracheal intubation. We used a weirder diverticuloscope to engage the Zenkers diverticulum. The posterior blade was passed into the pouch and the anterior blade into the esophagus. The blades were distracted to bring the cricopharyngeal bar into view, and the scope was suspended, as you can appreciate in the picture. The pouch lining was examined, and we did not find any suspicious areas. A diverticulotomy was performed with the laser by transecting the mucosa and cricopharyngeus muscle in the midline of the common wall to its most inferior edge. So post-operatively, the patient was given water sips and maintenance fluids. Free fluids were started on day 1 post-op, and the patient was discharged on the second day post-op on a sloppy diet and a proton pump inhibitor. On review 2 weeks later, the patient was found to be symptom-free. So my presentation today will be focused on Zenkers diverticulum. Zenkers diverticulum is a pulsion diverticulum, or a herniation of the esophageal mucosa and submucosa through Killian's triangle, which is a triangular dehiscence between the horizontal fibers of the cricopharyngeus muscle and the oblique fibers of the inferior pharyngeal constrictor. It occurs predominantly in the elderly, and it is rarely seen in patients aged less than 40 years of age. It is more common in men with a ratio of approximately 2:1. There are other areas of weakness where pulsion diverticula may form, including the lemur triangle, which is formed between the cricopharyngeal muscle and the most superior esophageal wall circular muscles. We also have the Killian-Jamieson area between the oblique and transverse fibers of the cricopharyngeal muscle, and more rarely, pharyngoceles may be found in the posterolateral or lateral areas of the pharynx and hypopharynx. There are several classifications of Zenkers diverticulum, but the most commonly used one is the Leahy classification, which describes 3 stages based on their radiologic appearance. Stage 1 describes the presence of a protrusion in the mucosa where no visible pouch can be detected. Stage 2 is a fully formed diverticulum with a distinguishable pouch and neck. And stage 3 represents large diverticula that extend to the mediastinum and compress the esophagus, causing food to pass into the diverticulum easily. And there have been several subsequent studies which have attempted to classify Zenkers diverticulum, as you can appreciate in the table presented. The three main theories currently proposed to explain the formation of a Killian pouch are, firstly, Killian's dehiscence, secondly, spasm or failed relaxation of the cricopharyngeal muscle that prevents the downward passage of the bolus and creates a high pressure above the cricopharyngeus that eventually causes herniation through Killian's dehiscence. And thirdly, we've got incoordination theories. And as it is stated in Scott Brown, incoordination between the descending peristaltic wave and failed cricopharyngeal muscle relaxation, creating an abnormally high intraluminal pressure, subsequently leads to mucosal herniation through the weak area of Killian's dehiscence. So a thorough history may raise suspicion of a Zenkers diverticulum. There are several hallmark symptoms, which are progressive dysphagia coupled with postprandial regurgitation of undigested food, halitosis, weight loss, noisy deglutition, coughing, globus sensation, and recurrent unprovoked aspiration. Physical examination is often normal, and rarely Boyce's sign, that is a swelling in the neck that gurgles with palpation, is present. The endoscopic view of the larynx and pharynx may show pooling of saliva, and the rising tide clinical sign can be appreciated during flexible endoscopic evaluation of swallowing using fluids, usually with water or milk with dye, and small amounts of swallowed fluid can be seen to rise up from the post-cricoid region after the bolus has disappeared from view. Diagnosis is confirmed with a contrast swallow and video fluoroscopy. Fiber optic endoscopy is then done to rule out other causes of dysphagia, as well as to document vocal cord function. Carcinoma in a Zenkers diverticulum is rare, with an incidence of less than 0.5%. Rapid onset dysphagia, pain, or blood-stained secretions should raise suspicion for malignancy, and a constant feeling defect on serial barium swallow studies should raise concern of a tumor. At surgery, it is essential to examine the lining of the pouch and biopsy any areas that look suspicious. However, carcinoma rarely can arise in the pouch wall following endoscopic division of the cricopharyngeal bar and of the pouch excision, usually at the junction of the pouch and the esophagus. So the management options for patients with a pharyngeal pouch can be divided into three groups: conservative, endoscopic surgery, and external approach surgery. Observation with dietary manipulation is a reasonable option for relatively small Zenkers diverticuli, or in patients with minimal symptoms, or those who pose a significant anesthetic risk. The surgical approaches include the following. So endoscopic approaches include cricopharyngeal myotomy and diverticulotomy, which can be achieved by laser, stapling, or electrocoagulation. We've also got external transcervical approaches, which include cricopharyngeal myotomy, inversion diverticulopexy, that is suspension, or diverticulotomy, which can be achieved by suturing or stapling. Okay. Okay. I'm going to repeat this slide. I was told I could not be heard. So surgical approaches include several options. We've got endoscopic approaches, which include cricopharyngeal myotomy and diverticulotomy, which can be achieved by laser, stapling, or electrocoagulation. We've also got external transcervical approaches, and that includes cricopharyngeal myotomy, inversion diverticulopexy, that is suspension, or diverticulectomy, which can be achieved by suturing or stapling. In terms of surgical anatomy, a Zenkers diverticulum is a thin-walled sac lined by stratified squamous epithelium with a thin layer of fibrous submucosa. The muscular layer of the hypopharynx is absent from its wall, and the common party wall, as you can appreciate in by the yellow lines, by the yellow arrows rather, contain the cricopharyngeus at its upper edge and separates the esophagus from the diverticulum. And of surgical importance is that the entire diverticulum is contained within the buccopharyngeal fascia, as demonstrated by the green line. It is very important to take great care to preserve this fascial layer when completely dividing the cricopharyngeus muscle, because disrupting this fascial layer can lead to saliva tracking into the mediastinum and causing mediastinitis. Advantages of endoscopic procedures compared to external procedures are the brief anesthetic time, early oral intake, short hospitalization, minimal pain, and revision surgery is not compromised by scarring. The choice of the operating diverticuloscope depends on the procedure to be performed. For instance, the Benjamin diverticuloscope has straightened tips, while the Weirda diverticuloscope is bivalved. The Benjamin diverticuloscope provides an optimum combination of visualization and ease of placement, while the Weirda diverticuloscope provides additional anterior to posterior volume by opening the blades of the scope, and this is essential for instance, for using the stapler technique. However, it is more difficult to insert in patients with narrow interdental width. Passing a diverticuloscope can be difficult in some patients, and if one is not cautious, it may penetrate the posterior pharyngeal wall or the pouch, and that can cause cervical sepsis and mediastinitis, as shown in the picture, where one can appreciate a perforated pouch. Endoscopic surgery procedures usually completely divide the common wall between the esophagus and the diverticulum, that is a diverticulotomy, thereby incorporating the diverticulum into the esophageal lumen. And in the process, also perform a cricopharyngeal myotomy. Endoscopic carbon dioxide laser is more effective than endoscopic stapling and usually results in significantly less recurrence. And this may be because the endoscopic stapler does not divide the most distal part of the common wall between the esophagus and the diverticulum. But in parts of the world when neither a stapler or a carbon dioxide laser is available, a long suction cautery can work in place of the laser. Importantly, consideration must be given to the flexibility and the disease of the cervical spine. And also the need for paralysis should be discussed with the anesthetic team, because muscular tone may limit visualization and may complicate placement of the scope. The common wall, the common party wall is visualized using an operating microscope with an integrated carbon dioxide laser, and a diverticulotomy is performed with the laser by transecting the mucosa and the cricopharyngeal muscle in the midline of the common wall to its most inferior edge. Some surgeons place 3/4 vicral sutures to close the mucosal defect, even though this is not required because the periesophageal fascia is intact. Carbon dioxide laser has the advantage of dividing the party wall up to the most inferior aspect of the pouch, and is often used to divide the residual lip of the stapled use. It is especially useful for pouches measuring less than 4 centimeters, because the stapler does not divide the distal 1 to 2 centimeters of the party wall. And as shown in the picture, the Zenkers diverticulum on the right is too shallow for the stapling technique. So the laser has therefore the advantage of being able to complete the entire task. However, asymptomatic post-surgical subcutaneous emphysema is said to occur slightly more frequently following carbon dioxide laser than the endoscopic stapler. Cricopharyngeal myotomy forms part of the diverticulotomy procedure, but it may also be done in isolation for very small Zenkers diverticuli or for cricopharyngeal spasm. However, one must be careful not to disrupt the posterior layer of the periesophageal fascia. And compared to laser or diathermy, stapling is quicker, has a lesser risk of perforation and mediastinitis, provides good hemostasis, and avoids thermal injury to the recurrent laryngeal nerve. And a possible reason to explain why stapling leaves residual sap and has a higher recurrence rate is that the tip of the stapler cartridge extends beyond the end of the staples, and the staples extend beyond the razor incision. And one option to minimize this problem is to place traction sutures on either side of the planned myotomy, and pulling these sutures during stapler activation to maximize the length of the razor cut. In resource-limited settings with no access to endoscopic staplers and carbon dioxide lasers, electrocautery can be used to perform diverticulotomy. The common party wall is grasped in the midline with a pair of insulated surgical forceps, and monopolar cautery is applied to the forceps. And this is repeated as many times as is necessary to carry the myotomy down to the most inferior aspect of the common wall. Post-operatively, patients are typically observed overnight, and one should look out for signs and symptoms of mediastinitis, such as radiating back or chest pain, fever, tachycardia, despite adequate pain control. And the patient is usually started on a clear liquid diet the following morning following surgery, and may be discharged if he or she tolerates a clear liquid diet. And the patient should remain on liquids and soft foods for several weeks to prevent esophageal rupture being caused by large solid food boluses, and maybe progress to a normal diet over a few weeks. Historically, different open procedures were performed, including diverticulopexy and inversion of the pouch. For the diverticulopexy technique, after a cricopharyngeal myotomy is performed and the diverticulum is freed, the sac is tucked with non-absorbable sutures superiorly to the prevertebral fascia. And for the inversion technique, after a cracopharyngeal myotomy is performed and the diverticulum is freed, a purse string absorbable suture is passed extramucosally around the neck of the diverticulum, and the pouch is then inverted and the purse string suture is pulled tight, and the muscle fibers may then be approximated over the defect. However, the success rates are significantly higher with open diverticulotomy. The primary indication to treat Zenkers diverticulum in an open fashion is inability to gain adequate exposure using transoral endoscopic techniques or with an extensive large Zenkers diverticulum. Rarely, the anatomy of some patients will prevent adequate endoscopic exposure. In the interest of time, I will not go into the surgical technique, but I will highly recommend reading an excellent chapter on the topic in the Open Access Atlas of Otolaryngology, Head and Neck Operative Surgery. A drain and a nasogastric feeding tube are inserted after the procedure, and antibiotics are continued post-operatively for 24 hours. Nasogastric tube feeding is continued for about a week, and oral feeding is introduced if the patient is swallowing the saliva well with no symptoms at the end of the week. If the patient's neck is sore or they are having a hard time to swallow, a barium swallow is performed to confirm that there is no leak before starting oral feeding. Complications can occur during surgery, and when performing endoscopic procedures, those are damage to the lips, teeth, tongue, and gums. Bleeding is a potentially dangerous complication, as a hematoma in the neck can result in airway compression. Esophageal perforation and a subsequent leak are the most feared complications of Zenker diverticulum surgery, and these can occur both with endoscopic and open procedures. Mediastinitis can occur because the fascial planes in the neck are continuous with the mediastinum. And if that happens, the patient should take nothing by mouth, be on nasogastric feeds until the perforation heals, and broad-spectrum antibiotics should be started empirically. Injury to critical structures in the neck, especially the recurrent laryngeal nerve, may occur, and this can be identified if the neck of the diverticulum is more inferior than is usual. Post-operative wound infection can occur if diverticular contents are spilled into the neck, and a stricture may be caused by excising too much tension on the sac wall with an open diverticulectomy procedure. When recurrence does occur, the diverticulum is often wider, and recurrence is more likely to occur after endoscopic stapling due to the inability to extend the diverticulotomy to the most inferior edge of the sac. And symptomatic recurrence can progress to the point that the revision procedure is indicated. Intraoperative measures to decrease the chance of recurrence and complications include the use of retraction sutures to help position the common wall and allow the stapler to be placed for maximal sectioning, and removal of any loose staples or retained sutures immediately after the common wall is divided to prevent mucosal edge irritation and subsequent restenosis. Reflux may irritate the freshly divided edges of the common wall and encourage scar tissue formation during the healing process, which results in early restenosis of the common wall and recurrence of symptoms at an earlier time point. And furthermore, gastroesophageal reflux has been postulated to lead to cricopharyngeal spasm, and this may predispose to the development of Zenkers diverticulum. So in conclusion, the short-term results with endoscopy procedures are superior to external operations. Endoscopic stapling and laser division are quick and bloodless, are associated with minimal discomfort and avoiding the need for a nasogastric tube. Endoscopic techniques allow early oral intake, early hospital discharge, reducing morbidity and costs that are historically or traditionally associated with pharyngeal pouch surgery. Those are my references. Thank you.
Excellent summary. Just a few comments. Firstly, it's a procedure that I never talk patients into. It's really a quality of life issue. And the only ones where you would try to persuade the patient having done it if they're having problems with aspiration pneumonia. So otherwise, I'm very cautious about trying to persuade patients to have it done. And often, as you point out, simply by modifying your diet, you can control the symptoms. So that's the first issue. Second issue is that unfortunately we don't have a stapler available anymore. The company that produced these have actually stopped doing so internationally. So that happened only in the last 6 months to a year. So all around the world, people have now had to move towards using CO2 laser for cautery. Thirdly, there are some gastroenterologists that will do it with a flexible scope and using cautery, and they do those often as I believe as the daycare procedures. So certainly that's something you need to mention. The next issue is that I don't keep the milk about. I don't keep my liquids and sloppy diets for weeks on end. I think by the end of the week, the tissue should have stabilized. So I always tell the patient to stay on a sloppy diet for at least a week and then progress from there. I don't routinely give antibiotics very often, but I wouldn't fault anyone for doing that. The other important issue is you can tell your anesthetist not to bag the patient when they are reversing the patient from the anesthetic, because there is a leak into the tissue. So if you bag the patient, you get passive surgery emphysema. So they must be very cautious when they reverse the patient's anesthetic. And then the last issue was that that some patients do get symptomatic reflux after the procedure if they have an incompetent gastroesophageal sphincter, because I think those patients often rely on the competence of the upper esophageal sphincter. So you do get the odd patient that says that they've got symptomatic reflux that you can have prior to the surgery. So those are really my comments. I very rarely do an open procedure because one gets away with this. Also, the other issue is there's no point in doing a barium swallow or contrast swallow after the procedure, because they're all going to have a dilated proximal esophagus, and you're only going to do it in patients who are symptomatic down the line to see whether you need to do some more. So I don't routinely do a contrast swallow following the surgery. And you also have to caution your patient that the swallowing is never going to be 100%, because that part of that part that you incorporate into the esophagus hasn't got a muscular wall. There's always going to be a slower transit time at that level. So those are really my comments. Yeah, a very nice summary.